Hello, welcome to your newborn lecture. We're going to start with your head to toe assessment. Please make sure that you review all of the expectations. This is the culmination of what we did for you on your first clinical day. And always remembering that before we can do a head to toe assessment on the neonate, we need to know the medical and antenatal history of the mother, what happened in the labor, and then we start with our APGARs. Okay, so always easiest to start from the head. Again, we went over this with you in assessing the fontanelles, the shape of the head, and we'll get a little bit more in depth around what's happening with the head, looking at the face, assessing for any nasal flaring, looking at the eyes, making sure that they line up with the crease in the ear. You will check for your suck reflex or your root, and then your suck. At the same time, you will see your hard palate and palpate that as well to make sure that there aren't any clefts there. Going down to the clavicles, you will palpate for your crepitus. Then you can go across the arms and do your startle reflex. You also want to make sure you're looking at the baby's nipples, looking at the rib cage and assessing if there's any signs of respiratory distress. You can go from there to your cord, assessing that it is a 3-vessel cord and that your clip is well intact. That's the next point where you go down to the hips and assess for the congenital hip dysplasias. You can also assess genitalia at that time, and then you can go into your Babinski reflex, which is your upside down J. Remember to count fingers and toes, turn your baby over and assess the back. All right, you're looking for any tufts of hair or dimples in the gluteal folds to make sure that there isn't a spina bifida there present, okay? You always want to make sure that you are teaching the family and reminding them that acrocyanosis is normal. And you also want to incorporate the family in any care that you're giving to the patient, making sure that you're providing explanations. Now let's talk about the head. So the caput secundum versus a cephalohematoma, you will need to know this for testing, especially on the NCLEX as well. The cause of this is important to know because the risk factors of when a baby will have this as they're delivered will tell you what your next steps are. So remember that in caput secundum, this is an inflammation related to pressure on the scalp. Usually it's when a mother is in labor and her labor stalls out. So you will literally have a 5-centimeter caput because the fluid collects in the tissue due to the pressure of the labor on the head. It is normal when it's central, and it is not normal if it's not right in the center of the head, okay? The reason being that that's an indication that the baby was asynclitic or the head was rotated in a position that was making labor difficult. This sometimes is what you see above and beyond and in addition to molding, which is the normal molding that happens when the baby's leaving the birth canal. Another thing to note as well, that the cephalohematoma is where we actually have a break in a vessel and we have bleeding into the space of the tissue. Now, the things that would make this a longer risk or a more common risk is any type of instrumentated delivery. For example, your vacuum extraction. So the most important thing to remember, which is one of the key statements that you'll see on exam question, is which one crosses the suture line and why does it cross the suture line, okay? So the cephalohematoma generally does not cross the midline or the suture lines. And the reason for that is that the boundaries of a cephalohematoma are defined by the underlying bone, okay? So it's confined into that area because the leaking is happening around the periosteum, all right? Which is different than the caput secundum. These two can coexist, which makes diagnosis very difficult. One of the things that I've found in my practice is that the caput tends to be more dense, and then the cephalohematoma is softer, okay? So it takes like years and touching lots of babies' heads to understand and see that piece, All right, we never are required to diagnose this, but we will report this out on our assessment, and we will be mindful of our vital signs, simply because the caput candidum will self-resolve through absorption, but the cephalohematoma could cause a hypovolemia. The baby can lose their entire blood volume in the scalp. So very important for you to be aware of. Here are some examples of the natural molding that we see in babies. This is most likely an occiput posterior baby, right? So baby is face up in the posterior when the occiput is posterior. And so this pressure on the head allows for that molding to happen, okay? In the caput secundum, this again is where labor has stalled in general, and we are just collecting fluid here. And then here's the cephalohematoma. You'll notice this does cross multiple suture lines. This does not cross the midline. Okay. Here's another example, too, of a caput secundum. You can see here versus the cephalohematoma. So remember, you need to know the definitions and what causes these things and what your nurses and nursing interventions will be. So this is the Ballard scoring system. Know that what you have to understand about this, because this is like a postpartum and NICU level skill and newborn nursery skill, okay? It takes quite some time to memorize and to be able to score appropriately. And so you're not being asked to do any scoring, not for the NCLEX nor for any of my exams. What you have to understand, and this goes back to our antepartum lecture where we were looking at the gestational age of the baby and what we expect to see if that baby were to deliver at that time. Okay, so receiving a description would not be inappropriate for one of the assessment components, but that is more important than understanding how to score at this point in your education. Okay, so for example, the younger the baby is, the less neurologically mature the baby is, and the less they're mature in the musculoskeletal system, the less they have as far as the thickness of skin. They tend to go through a phase of lanugo, which is the hair, where they have none to sparse to abundant, and then it thins to bald to mostly bald, okay? Same thing with the plantar surface, and here is an example of that. You'll see in a baby that's 28 weeks gestation, okay? First, they'll measure the heel to toe length, and then they'll look at the creases. So here you don't see very many creases in the feet, so the little lines, okay? As the baby matures, what we get is some faint red marks, okay? And then the anterior transverse crease is there here, okay? And then as the baby becomes more mature, you see lots of creases in the foot. So this is the difference between a 28-week foot, a 32-week foot, and then a 36-week foot. Okay. What we'll see too around the eyes is, depending on the gestation, the eyes can be fused still. Sometimes the lids are open, and then they're comparing the eye and the ear at the same time. Okay. Same thing with genitals. Some of the places that I look quickly as a person that has had to do Ballard scores, I look at the skin, lanugo, plantar surface, and then I look at the genitals, okay, because the genitals are pretty telling. All of it, though, is relevant, and all of it is required to make a Ballard score, okay? So this is a really good explanation as well, and what I have here is the opportunity to bring in that post-mature syndrome, okay? So a baby that's less than 28 weeks, you can see that they got hair on their backs, hair on the face, hair on the head. You can barely see the eyes open, okay? When you look at the feet, they are very smooth with not very many creases in them. When you look at a full-term baby, you can see the difference in how many creases we see in the feet. You can see that this baby is primarily bald, that their skin is not as red and translucent as this can be. And you'll see the translucency generally on the abdomen and on the face and head. And then here is a baby that's been more than 42 weeks post-mature, okay? This is that baby that our first intervention always is to confirm that the dates are correct. And that's very, very important, right? Because sometimes they make mistakes with things like that. Their most urgent risk is death because that placenta is calcifying. So this baby, you can see, has skin that's peeling. Okay, the feet are peeling. The feet are very well creased. Okay, so that's a good little example. Now, these are not perfect textbook examples, but just to give you a sense of what's happening. Okay, so moving on toward lactation, we want to help families understand that breastfeeding is a lot easier once we have a baby that is not crying and angry and upset, okay? So early cues mean I'm hungry, mid cues mean I'm really, really hungry, and these late cues are I'm upset, I'm angry, and I'm fighting, okay? So this stirring baby is looking around for the breast, they're licking their lips, they're opening their mouth, okay? And they will actually seek out the breast. This baby will very readily and easily have a deep latch because they're not angry and frustrated. This baby here now is one that is starting to get irritated, essentially. So they're going to start stretching, they're going to be moving, they're trying to eat their hand because they're really hungry, okay? Now, once they get to the cry, what I want you to notice is how high this tongue is. And so it's much harder to get a good latch into this baby's mouth when the tongue is up because they're crying. They also tend to be more aggressive and less patient with the latch, so the latch is much harder to achieve when the baby is experiencing these late cues. Okay. There is about a 12 to 18 hour, sometimes up to 24-hour recovery period that we talked about in that initial newborn transition during our intrapartum lecture. And that has to do with them recovering from the labor and the delivery. So we want to get the baby at least breastfed within the first couple of hours after birth because we know that they're going to go into that sleep period. There is no biological reason in the normal term infant for us to wake up a baby every 4 hours in the first day to make sure that they eat. Parents absolutely have the right to request a blood sugar over a bottle when a baby is sleeping, okay? This is very different than a baby that's hypoglycemic and non-reactive, okay? So you have to be able to make those decisions, you have to have a full history, like we said, of the antenatal and maternal health, and then as you'll also need to have your entire labor history as well to be able to make those decisions. What we don't want is nurses feeding babies because it makes the nurse feel better, okay, which is one of the greatest challenges that we experience as pro breastfeeding in our hospital facility's mission to be a baby-friendly hospital. Okay. Babies generally will spit up in the earlier neonatal period rather than as the baby grows because they have a more relaxed cardiac sphincter. And so that is meaning that reflux can happen more commonly in that initial period. Okay. Please, again, breastfeeding amenorrhea is one of the least consistent birth control methods. So we need to encourage a second option, preferably a barrier method should the family wish to, or the couple wish to engage in sexual activity during the breastfeeding period and before the 6-week appointment. So important as well, again, you will see questions around signs of sufficient nutrition, and families will ask this of you as well. So how many dirty diapers do you expect to see, right? If the poop is seedy versus if it's pasty versus if it's meconium, you have to know the difference between your poops. That's why we did that station in your clinical. Also, how many wet diapers, right? Because that's hydration for you. How do you know they're well fed? We talked about it. Look at the hand. Look at these babies who are nice and relaxed and these babies who are mad, they're tense. Think about yourself when you eat, right? Before the meal, you're kind of, attentive. You may be even hangry, you're tight, you're reactive, and then after you eat, you're nice and relaxed, you're kicking up your legs, and all of that good stuff. All right. So vital signs will change as the baby grows, okay? And this is something that you'll need to memorize for fourth block. So please note that. And during your winter break, get yourself some flashcards because you will be required to know your vital signs for each each pediatric stage. So as far as fetal monitoring is concerned, the younger the baby, the higher the baseline in electronic fetal monitoring. And the reason for that is because they're still developing in their brain. So you will see less variability, shorter and smaller axons, okay, and you'll see a higher baseline, and that is appropriate for the gestational age. So a 24-weeker will have a higher baseline, minimum variability to moderate variability, and then they will have axons that are only 10 by 10s, which is different for babies that are older, okay? Again, we always want to see that whatever our heart rate was in the labor, in the antenatal period, our baby should deliver close to that, okay? Now, let's look at situations like if the baby or the mother has chorioamnionitis, right? It would be appropriate for that baby, based on the maternal temperature and the infection, to be hanging out in the 180s, right? So when that baby's delivered, I'm not nervous that this baby's heart rate is 180 because they were delivered from a mother that had chorioamnionitis and their heart rate matches what it was in the labor. Now, after the baby's delivered and they're no longer existing in a febrile environment, they should start to bring their heart rate down. So if by 3 hours of age, the infant or the newborn is technically a newborn, so 28 days of life, just want to make sure I iterate that point. If the heart rate doesn't come down by a couple of hours because they're not in that hot environment, then that's not normal. And so that baby might be considered for additional antibiotics, okay? Be mindful of this because you will see questions that ask about, vital signs, and they're giving you maternal history and labor history to assess if you can recognize if the vital signs are appropriate or not, okay? So we don't ignore it if it falls within the normal range, if the normal range doesn't match what it was in the antenatal and labor time frame. And we also don't overreact to abnormal vital signs that are the same as what we expected in the labor process. Now, this is not talking about obvious signs of respiratory distress, right? This is just talking about baseline vitals with no concerns at that point, okay? So cord care is very important as well. We will clamp the cord and then it starts to dry itself off and then it will fall off. Okay, it dries up and falls off. So we do not want them immersing the baby in water while the cord is still present, okay? They're supposed to clean it just with a Q-tip or an alcohol swab to keep it nice and dry. You do need to teach the parents to be mindful of what an umbilical cord infection is. This is very serious because this is straight into the peritoneum, okay? So signs and symptoms of infection are a very important part of patient teaching. On your NCLEX, as you are the RN, and it is rare to see LPNs working in labor and delivery, but they do very actively work in postpartum, antepartum, and CNAs actually you see more than anything, okay? So being given a nursery assignment where there's a bunch of LPNs or an LPN working, you have to be able to state which baby is okay to leave in the nursery with the LPN, okay? So you'll get an example of scenarios for a bunch of different babies, and then you'll have to select which babies are appropriate or inappropriate for the care of the LPN, okay? This is something that you will see overall on the NCLEX delegation to the CNA, delegation to the LPN, requests by the physicians that are inappropriate. So important to make sure you're clear on delegation. So circumcision we have to talk about because it does happen, though since Medicare stopped paying for it, as it is not medically necessary, we have seen a significant decrease in circumcision in American babies. Our country is one of the very few countries that actually do perform routine circumcision. The rest of the world, most men are uncircumcised. So it's only an occurrence that we see in this country. So there's a couple of ways that it can be done. It is a major medical procedure, and it does have negative outcomes at times. So we will need to teach the patient about the appropriate care of the circumcision. Generally, the majority of pediatric physicians do not do circumcision in the hospital any longer. Very rarely you do have one that does it as a patient service, but it is far and few between than it was earlier on in my practice many, many years ago. So the GOMCO is a clamp where they will numb the penis, and they actually use sucrose as pain medicine because that functions that way in the baby's body. So your baby is not getting morphine, your baby's getting a sucrose pacifier or a pacifier dipped in sucrose, and your baby's getting local anesthesia. So that's how this procedure is done. So essentially they will pull the penis through, and the bell goes underneath the foreskin, and then they literally just cut around it. Okay. There is also a plastibell, which is a tying procedure. So the GOMCO actually goes on, and then they tie it until the foreskin falls off. Okay. And then there's the Mogan clamp, which I have not really seen in my practice. I'm not sure how much it's utilized. I will not ask you the different types of circumcision methods. What I need you to know is how this works so that you can teach the patient about what they're going to see. Usually there is a family member with the baby in the procedure. You can well imagine that dads don't do as well as moms, but moms don't do well either when this happens, okay? So it is a sterile procedure. Again, the baby is tied down into this little device where their arms and legs are secured so that they're not kicking. Sucrose pacifier, and then local anesthesia. The diaper has to be, so they will put a gauze on the incision with Vaseline on it. So it's one of those wanting to heal from the inside out kind of situations. We don't want to put dry dressings on the baby because the normal exudate of the serosanguinous healing process will cause it to stick. And then the tissue will get ripped away along with the removal of the gauze. What we tell parents to do if they find that their gauze has stuck is just to dampen it until it's soft enough and just peels off gently, okay? Very, very important. So a gauze with Vaseline, okay? So and the Vaseline side onto the penis. Okay, moving forward, we want to talk about the screenings, tests, and procedure. So we're going to extract some blood, some venous blood from the cord segment, and we will get our CBC, bilirubin, type and screen, RH factors from there. We also do that arterial blood gas on the cord, and we get that from the artery, okay? And then we can also do blood banking, which we discussed at length. The ABG functions exactly as you learned it in Block 2. They will look at the pH, and then they will assess if it was metabolic, which in utero, it looks a little bit different, but you're not being asked to know ABGs. ABGs for us are important because they give us a sense of neurological injury based on absent variability, repetitive D cells. You know, we can recognize that we're going to have concerns with the fetus's ability to maintain oxygenation and not become acidotic or hypoxic from that ABG. Okay, so same theory as what happens in the breathing adult as what happens into the intrauterine environment. When we have acidosis, then we assume that there's a lot of hydrogen in that brain, and that's where cerebral palsy comes from. So the ABG will tell us if we need to do cool caps which is actually icing the brain to decrease the swelling to stop the neurological injury of the acidosis to the brain. Okay. So you're going to go into much more depth in this testing process in pediatrics, but there are metabolic disorders that we test for, okay? If you look at this picture here on the left, what you will see is that we take 1 drop of blood through a heel stick, and we will put 1 drop into each of the circles. They will take this and then run the test to determine, does the baby have sickle cell, right? Is there congenital adrenal hyperplasia, cystic fibrosis, galactosemia, sickle cell, okay? And so all of that is found in this one particular test. So this is a mandatory test that happens for the baby. We also would do a hearing screen, and no baby leaves the hospital without these tests having been performed. And so what it does is it places sensors on the brain, and then it makes little sounds, right? Because the baby, if you remember getting this test when you're a kid, they would tell you to raise the hand on the side where you heard the clicking, right? Or the noise. So this is actually listening or assessing for brain activity as the clicks and sounds are happening on each side of the baby. The other test that we do is our pulse oximetry test to assess for congenital heart diseases. You will go in incredible depth in this in PEDS in Block 4. It's actually quite fun. Make sure you review how the drop of blood moves through the heart and that you have a strong command of your cardiac circulation in the adult. It will make your life a lot easier, okay? All right, so we talked about the ductus arteriosus, which is this extra fetal adaptation in the intrauterine environment, okay? So if we follow this drop of blood from the superior and inferior vena cava, right, and we go into the right atrium, down to the left ventricle, and then we go across and out, we also have this duct that is providing blood flow to the aorta, okay? This ductus arteriosus here has a specific time frame in which it has to close, all right? Sometimes when we have a very severe congenital heart issue, we want that to stay open. But in most babies, it should close in a very short period of time after delivery, okay? So the way that we assess for that is we're going to test on the right side of the body by putting a pulse oximeter there. And then we're going to go to the left side of the body and go to the left foot. So we recognize that as blood returns back from the lungs and goes over into the left atrium, left ventricle, into the aorta, then there will be a different concentration of the pulse ox versus the right side of the body, okay? So that is a point that is very important. The one pulse ox has to go preductal, meaning the blood flow before the ductus arteriosus, and then the left foot is the postductal, or the percentage of oxygen in the post or after the duct circulation, okay? They say you can use the left hand, the left foot, or the right foot. I recommend that you stick to the left foot and the right hand because there is no concern for forgetting. This is where you got to pick up your left finger and make an L and your right finger to remember which is left and right. Be very cautious and approach this not with a sense of hurriedness, but making sure that you're applying it correctly, okay? Now let's look at how the test works in and of itself. So we will place that sensor, right, on the right hand, and then again on the left foot. And when it is negative, that means that your SpO2 is greater than 95% in the hand or foot, and the hand or foot difference is less than 3%. If we find that there is a difference of greater than 3% and the SpO2 is 90 to 94, then we want to repeat it 3 times. We will repeat the measurement in an hour, okay? But we want to confirm that what we're seeing is consistent, all right? Because sometimes it takes a little bit for that thing to close, all right? If it's positive, that means that we are less than 90% oxygenated in the hand or the foot, or we've repeated it 3 times and it's positive. We don't do anything about that. We refer them to the echocardiogram, refer the infant to the physician, and the physician will do an echocardiogram for further medical evaluation. All right, so hypoglycemia, very important for you to know the signs and symptoms of hypoglycemia. You will be presented with a baby with a history and signs and symptoms of hypoglycemia, okay? Knowing your risk factors is very important. We discussed that at length in your high-risk antepartum as well as in your intrapartum. And so very important for you to be able to identify the baby at risk as well as identify the baby who is experiencing signs and symptoms of that, okay? It is not my expectation that you know the protocol for neonatal hypoglycemia management. It is extensive, okay? So again, prevention techniques, critically important, signs and symptoms, risk factors, and all of that, okay? Generally, we will have a threshold line of a number that says whether or not the baby is hypoglycemic. And then depending on what that number is, there's a range that says feed and recheck, or bottle feed, right? And then recheck, or go straight to providing glucose for the baby. Okay, so like glucose supplementation, PO, and then depending on where it goes from there, it could be IV and NICU admission. If you delay interventions with neonatal hypoglycemia, it results in severe neurological loss. So very, very important that we stay on top of it. Okay, so moving into neonatal hyperbilirubinemia. We've got pathologic or physiologic. If it is physiologic or pathologic, it has a certain number of criteria that make it that. So make sure that you review what makes it pathologic or physiologic. I won't regurgitate your book for you in that regard, but I will teach you some tricks and tips in class, and we will go over a protocol for a baby, okay? Our interventions are phototherapy, and we know that our babies that are at highest risk are babies with ABO and RH incompatibility. These are some different types of lights, or they call it Billy lights. Very fun was that the nurse that discovered this disease process put her babies by the window. And for one type of hyperbilirubinemia, we treat it just by having the baby be outside. Okay, not in direct sunlight, friends, not in direct sunlight, okay? So the actual vitamin D and the sunlight helps to decrease the bilirubin. Now, why do babies have higher bilirubin naturally, which is physiologic versus pathologic? Because of all the extra red blood cells that the mother's body creates to support the pregnancy. So again, this goes back to antepartum and the development of the fetus inside of the mother and the maternal adaptations to pregnancy. Okay, so here's all that stuff coming back in. Okay, so this is a Billy blanket. Okay, 2 different versions of that. These are Billy lights, and intensity changes based on how low or high it is. And then there are the ones like my son had, which looks like a suitcase and a tanning booth. And so you put the baby in that. As much as possible of the baby's skin needs to be exposed. We need to protect the baby's eyes from these ultraviolet lights. And so the baby's eyes must be covered. Nutrition is incredibly important, particularly hydration. Because think about laying in the sun at the beach without nary a drink of water, okay? So we need to be assessing for appropriate urine output, wet diapers. We will be weighing these diapers to assess the output. We want to have frequent feeds. We want to ensure temperature regulation because the baby's skin needs to be exposed to this as much of this light as possible, okay? Assessing the diaper also is interesting because the diaper will become more of a clay color, just like you see in the adult with a liver issue, and you'll learn more about that in med-surg. And then you'll see it come back to its normal color. You will also see the jaundice on the actual baby's body start to resolve itself as well. So some very important things that we had addressed in your newborn assessment in labor and delivery is that initial transition period. So when that baby is taken from the wet environment, the little fishy environment, and put onto the mother and the warmer, cold stress is a very important thing to consider. The second you turn your warmer on to prepare for the delivery, you have addressed the intervention for cold stress. So interestingly, it is truly your first intervention is turning that warmer on before the baby's even delivered. So the ways that babies lose heat, you must memorize this. What is conduction? What is convection? What is evaporation? And what is radiation? Okay, we talked about this a little bit in your clinical day. So conduction is when you have direct heat loss that goes from the baby's body onto the surface or into the surface in which they're in contact. So if I put the baby on the scale and I don't put a blanket down between the baby and the scale, that baby's going to lose a lot of heat through the method of conduction. Convection would be the process by which we have a warmer and we have not put the sides of the warmer up. So we've got air currents going across the baby. This also is related to having the warmer underneath the air conditioner fan in the room. Okay, so make sure that you're mindful of where your AC is blowing in the room and that you don't put your baby right underneath it. The other consideration here is evaporation. So this will be drying the baby immediately after they're delivered and removing the wet blankets from underneath the baby in the process of the initial resuscitation. Okay, so that's another example of how that works. Radiation would be the heat loss via electromagnetic waves from skin to surrounding surfaces. Okay, so this is heat loss that is just radiating off of the baby, and our intervention for this is to put them in an isolette, okay, or to wrap them up and put them in warm clothes. So make sure that you are aware of the examples of this in life as well as what our interventions are. Very, very important. When a baby has cold stress, they will burn their sugar. They will burn up their brown fat. Okay, that's part of why they have brown fat. So make sure you review that information. And it's very important that we don't just take a cold baby and cook them. That causes them to go into pulmonary edema. So you have to rewarm them very slowly and very gently and very intentionally. For me, one of the fastest way to warm a baby is to put them on the mom's chest with warm blankets on top of the both of them. However, if your temperature is too low and your facility will determine what that temperature is, then your baby has to go underneath the warmer and has to have a temperature sensor on their skin to be able to ensure that we're not warming them too rapidly. Okay, so neonatal sepsis, we talked about all the different reasons why a baby would be at risk for neonatal sepsis. But one of the things that I want you to be mindful of is that the early onset sepsis happens within the first 2 to 3 days after birth. Okay, so some of this sepsis we will not see because many deliveries will get discharged within 24, at most 48 hours. However, if we have risk factors, then obviously that mother's going to go through a round of antibiotics before discharge, in which case we would have time to assess the baby. Some prophylaxis that we do is we will treat the baby with antibiotics depending on the nature of the septic infection for the mother or the bacteria that the mother's body was encountering while the baby was still in the uterine environment. Okay, late onset sepsis happens between 3 to 7 days after birth. Okay, so early diagnosis is very, very important, and again, those risk factors, knowing those risk factors. What I want you to notice is that this baby is pale for his race, is not reactive, is spread out, okay, and the color doesn't look quite right. So this is just an example of what a septic baby could look like when you're walking into the room. You must know all of the signs and symptoms here, okay? Septic babies usually get cold, very interestingly. They don't get fevers, okay? So if you have a baby that's consistently cold, they will probably do some blood work to figure out why the baby's always cold, okay? Listlessness is the example of this. Sometimes we use words to describe our assessment data that are not words that you've commonly encountered before your nursing education. So things like sensorum, right? listlessness. These are all terms that you will see used regularly by different healthcare practitioners, okay? So a baby that is cold, a baby that's not eating, a baby that's tachypnic, a baby that's tachycardic, a baby that's pale. All these things are things that we will generally see before we see a change in temperature. Okay, so here we are back again for small and large for gestational age. Please make sure that you review the risk factors and information on there. You recognize that both of these babies are at risk for issues with blood sugar and temperature. Both of these babies are at risk for feeding challenges, okay? So make sure you review all of that from your text. Okay. We want to definitely, again, review the differences in your ability to identify cyanosis versus grunting versus a baby pooping, okay? So we'll go over this slide more in class so that you can hear the different sounds and we can correlate it to the video. So transient tachypnea of the newborn. Please be mindful, your newborn chapter has a whole lot of stuff that I don't need you to know. So make sure you focus on the disease processes that are in the module that are focused and telling you what you should be going over or not. When you do your mastery level prep use, they will cover every single infant at risk or newborn at risk disease process. So for your exam purposes, for your final, for your newborn exam, follow through on what I have here, okay? The things that I have also are the highest frequency in occurrence in the NCLEX as well. All right. So transient tachypnea of the newborn, a lot of times they say it's because in a C-section, because C-section babies are at highest risk, it's because they never got the squeeze, okay, from the vagina when they were delivering. Now, if that were the case, that would mean that every single baby born by C-section should have transient tachypnea of the newborn. But that is interestingly not the case. So make sure that you review the risk factors for transient tachypnea of the newborn and recognize that it is transient. So they're having retained lung liquid, and the best thing for them is continuing to cry and giving them time to rest and giving their lungs time to absorb the liquid. Okay, every once and again they would have to do a drainage, but in all of the babies that I've helped to deliver, I have not seen anything other than wait, oxygenate, support, and make sure they don't burn up all of their sugar. Okay, so make sure you review your interventions for transient tachypnea of the newborn. Okay, so respiratory distress syndrome. Okay, this is something associated with deficient surfactant. Okay, surfactant keeps the lungs from sticking, like the alveoli from sticking together. If your alveoli are collapsed, they cannot oxygenate, okay? So babies that are at higher risk for respiratory distress syndrome are your diabetic mothers, C-section deliveries, a birth asphyxia, okay, prolonged rupture of membranes, right? If the baby is preterm, okay, we will generally give steroids to try to support this surfactant production, all right? But it really isn't deeply present until after 36 weeks. So any baby under 36 weeks is at risk for respiratory distress syndrome. What you have to see also is the signs and symptoms that give you the indication on top of the gestational age and the risk factors. When the baby is delivered, if we had, say for a preterm baby, the opportunity to provide steroids, they will put surfactant down the trachea at the delivery to help support the baby. So that is quite routine in a situation where we recognize that as the baby's transitioning, things are not going well. They can do that. The other part that they will do is they will intubate, okay? They'll intubate the baby, move the baby to the NICU, and then continue cares there until the baby's able to keep their alveoli open, all right? Hyaline membrane disease is the other term that they use for respiratory distress syndrome. So remember that these terms can be used interchangeably. Okay? Okay, so for meconium aspiration syndrome, we recognize why meconium would pass in the womb based on the fetal monitoring or some sort of prolonged hypoxia that the baby experienced, some concern where the baby vagal, okay? So this is the disease process where the meconium gets into the lungs and it essentially creates a pneumonia, okay? So recognize your risk factors associated with this, which babies would be at risk for passing the stool in the womb, right? So hint, hint, right? Our post-term babies, right, are at higher risk. Large for gestational age babies are at higher risk, okay? Problematic fetal monitoring strips are at risk. So make sure you review all of the different ways that happens, okay? So your babies are tachypnic, retraction, cyanosis, hypotension, okay? It is not, generally they can't do anything about it. All they can do is just monitor and give antibiotics and give the baby the opportunity to self-resolve the pneumonia, essentially. Okay. So these are some examples of x-rays just so that you can get a sense of what you would see. So in transient tachypnea of the newborn, again, it's retained fluid, so it will look streaky. Meconium aspiration syndrome looks fluffy because the alveoli are showing up on the radiograph. Congenital anomalies or the congenital diaphragmatic hernia is when there is a hole in the diaphragm and the intestines progress up into the lung. So what you're seeing here is actually small intestine, okay, and large intestine in the honeycomb, okay? Hyaline membrane disease or respiratory distress syndrome, as you can see, looks hazy. Pneumonia looks patchy, okay? Effusion looks white out, and air-like syndrome or a collapsed lung would look black, okay? You can actually see the outline of the lung, the collapsed lung right here. So this is kind of similar to adults, and I wanted to show you that. Of course, minus this newborn specific kind of concern, okay? All right, preterm labor, right? Preterm babies, retinopathy of prematurity. You must know this. This actually affects low birth weight babies and babies born before 31 weeks. And what causes this is over-oxygenation at the resuscitation period and in the initial days and weeks after delivery, okay? So when you give too much oxygen, it produces additional abnormal blood vessels, and these things detach the retina. So anytime you see a little kid, like a toddler walking around with Harry Potter glasses, that was probably a premature baby that got retinopathy of prematurity, okay? So standard operating procedure for preterm babies or premature babies is to get the eyes checked. Okay, so you have reviewed erythromycin, hepatitis B, and vitamin K. I talked to you about how we use sucrose for pain management. So make sure you review all of that information and recognize that the GI tract, again, is unable to produce vitamin K on its own until about 7 to 10 days of life, okay? We will give hepatitis B immunoglobulin, also known as HBIG, if needed within the first 12 hours after delivery. So make sure you remember that. And that is only, again, if the mother is hepatitis positive or had no prenatal care and has high risk factors for having hepatitis. Okay. You will also remember that you cannot do a circumcision in the hospital if the baby has not received the vitamin K administration. Okay. Child abduction codes is considered a code pink. That is a universal code across the country. It refers to any pediatric patient, so it's not just babies, it's also the pediatric patient, okay? In Arizona. In other places, they'll separate it out for pink and purple depending on the child's age, but in Arizona, code pink is code pink, even in the pediatric hospital, okay? So this is the response. What we do is we all stop non-critical work. We all move to the exits of our unit and we start to observe for any suspicious behavior. You will need to know a little bit about the profile of the person or the assailant, because these are generally people who have suffered their own perinatal losses, have had a recent loss, a history of some sort of postpartum affective disorder. So there are people that are high risk for being an assailant. We ask that you keep the baby between the window and the mother's bed. The baby must always have their alarm on, their alarm band on, and also always be in the company of a banded parent or guardian. And this is an example of your hugs tag, which can be on their ankle. Sometimes they are connected to the umbilical cord, okay? And then you have your labs with your scans, okay? And your identification of the newborn with the mother.